Ishta ma'am, sir is
Yes.
joined.
Good
Can we
evening.
begin?
My apologies on the delay.
So, with due respect, can we begin?
Please, immediately.
So, dear doctors, good evening. I'm Dr. Isha Angadi, Medical Advisor, Zydus Healthcare. I welcome today's to the webinar titled Case-Based Learning in Urogynecology for Busy Gynecologists, which is going to be a case-based learning. At the outset, I would like to thank each one of you to take time out from your busy schedule and attend this scientific session brought to you by Zydus Healthcare. We had an overwhelming response to the previous two digital master classes, which were conducted in the year 2020, where Dr. Pandey in first session addressed topics like the overactive bladder, recurrent UTI, and intestinal cystitis. Drawing conclusions and drawing truths from the success of part one, we also conducted a urogynecology masterclass as part two on a very good occasion, which was the 21st June, which is celebrated as the Father's Day. Sir addressed topics like the stress urine incontinency, urinary fistulas, and refractory vaginismus. These are both important topics for gynecology as well as in IVF practice. Now, without further ado, let me welcome our speaker for today. Sir needs no introduction, but I take honor to introduce him. Dr. Sanjay Pandey. We name his sessions as masterclass because he's master in urogynecology and heads the Department of Andrology and Reconstructive Urology at Kokila Dhirubhai Ambani Hospital, Andheri. He has experience in genitourinary reconstruction, andrology, female urology, endourology, general reassignment surgeries, botulinum toxins in urology. He has constructed knowledge in various subjects of urogynecology and conducts masterclass with forums across the country. I welcome Dr. Pandey and hand over the session to sir. Thank you, sir.
Thank you. If I'm clearly audible, Dr. Isha, thank you so much. At the outset, my apologies for having joined delayed. I have just come out of the operating room and ran into your location. And thank you so much for joining from all over. So to start with, it actually feels great and good to be there with you in more relaxed atmosphere of your homes, where you finish your weekday work and you hear around. Let's have some questions from you as it goes by, number one. And number two, thank you, Zydus, again, for having taken me to the forte of discussing topics which we continue to do all the time, continue to work. So thank you for being warriors on the subject. Straight away, moving on to a presentation to make it just a little bit more interactive, but you can always put in your questions. I wish I could see the questions directly. It could have made life much easy. Let's get going with a little bit of discussion on few topics, and as and when there could be timeout, we could stop it. You somewhere in the presentation on the first few slides also have my WhatsApp number, only for the reason that if it just in case gets delayed and you can't ask your question, you will have my number in the first few slides. You could always leave me a message, and I'm very keen to actually interact and take it forward. So thank you for coming in such busy schedule times. Just to take you forward, what does it mean and how have we used the word called masterclasses, with Dr. Isha did discuss about. Today we're looking at a little bit of urogynecology for all of you who are busy gynecologists, urogynecologists today. I carry greetings from Kokila Dhirubhai Ambani Hospital, where we strive together with you to look at improving the quality of life of individuals while we follow the motto every life matters. Friends, coping with busy gynecology practice, where each patient who sees you in your locations across the country says, I love my gynecologist. I think it probably behoves that we don't miss out on topics, but still is your domain. Your master's in the pelvis and perineum, and you continue doing great job there. People who have been doing this for decades together, and those who have just joined the gynecology fraternity, the session is to give you back the subject that belongs to you. And I've just put in my WhatsApp and my Twitter handle out here for you to connect and probably look at various things I put forward. So looking at this interest, the agendas could be many. I'm not sure we could touch all of them, but we'll look at attempting this, and looking at the response, we could probably make it happen again. So everything from urogyne basics to recurrent UTI, which as gynecologists you do so frequently, something on overactive bladder, something on stress incontinence, interstitial cystitis, bladder pain syndrome, the refractory vaginismus, which I deal so frequently now. I know that the primary vaginismus would never come to me, but refractory primary vaginismus, which I deal with botulinum toxin, and then the female urethral strictures, which I discuss here only to say that it is mentioned to be condemned to dilate such strictures. Ambiguous genitalia, another big time story. Gender reassignment, surgery, stones in pregnancy, injuries happening in urogynecology, where you and I happen to be partners, and then choice of catheters, stents, and sutures, etc. There's so much to talk. I'm sure over an hour, over 45 minutes, I'll attempt to do what? Dr. Isha, you could stop me as and when I am prolonging the session, but I gather everybody is in the comfort of homes. I sit in my department in my office after I completed a busy day, and happy to be connecting with all of you. So to looking at it, I never knew whether I would be able to, an year ago, speak on all these subjects, but that the evidence and experience is gaining so much on both sides, on your side and our side. It's nice that we combine together on many aspects in urogynecology, where women continue to suffer with negative cognitive, behavioral, sexual, and emotional consequences of urinary diseases. Take, for instance, somebody getting 5 UTIs a year, injectables, right from Ziffi-CV to meropenem, getting pyelonephritis. Somebody who has got bladder pain syndrome, somebody who has got overactive bladder or a stress incontinent, living on diapers, not drinking water. I mean, the issues are huge. Imagine vesicovaginal fistula. I mean, all these are massive. I'm sure many of you have taken up urogynecology in a very big way, but I would like to partner you in your cities and in your clinics, helping you out on this. So that we need each other. There are so many avenues as urologists and gynecologists, we need each other. There are some cases and there's some amount of discussion on each of them to know that why we should continue working with each other and take it to the highest possible level. Which means if we complement ourselves well, we possibly will go to the highest possible level. So that we are partners on many such diseases, let's embrace few of them today. Today's evening is important for that. So I remember we used to look at case-based aspects on overactive bladder, on recurrent UTIs, on mixed incontinence, which to treat first, and when does urodynamics come into picture, and then the urethral strictures and refractory vaginismus, and so much of fistulae, including the rectovaginal fistula. We did 7 of these rectovaginal fistula in the lockdown. So I can't imagine the number of cases that have come in around. And the IC bladder pain syndrome, but it's not a recurrent UTI, not an overactive bladder, but something else. So now that there's so much experience that you all have on the subject, and there's so much evidence around, we need to probably evolve to a level where expectations can be taken to the highest possible level. And friends, it's the best time to look at it. Those days are gone, but the days will come back soon where Zydus, this is a salute to you and the entire team of Sayesh and Mishraji, where we have been partners on a smaller sessions and we used to do live sessions around. Just to give you a little snapshot on the most memorable interactions, which went on for hours on case after case around, and each city we traveled to, we worked at. Looking at this important aspect, which I always talk to when I look at gynecologists as our colleagues, is that as a urologist, that I decided not to look at liver and spleen so much. I decided to ask for ultrasounds, which are ultrasound KUB. That means focus of my area if somebody has got a flank pain or a suprapubic pain. And when we were specializing ourselves as gynecologists, our job is basically to look at the pelvis. We're looking at the uterus, the 2 ovaries, we're looking at the entire pelvic structure, and therefore we are happy doing ultrasound pelvis on many of these occasions. So as gynecologists, we specialize and landed up doing the pelvic work. As urologists, we landed up doing the KUB or kidney ureter bladder work. But remember, n number of months, years ago, or our colleagues in general practice do ultrasound abdomen and pelvis. What does it mean? It is very important for us to look at structures which could be remote or which could be connected, and we sometimes miss out. An example of that is this. On the left side of yours is a patient who actually has got a stone in the kidney and is referred to a urologist. Take it for granted that it possibly could be me. So the patient is referred to me. And when we look at this situation, we know that there's a stone sitting in this kidney here. Now, this patient also has a situation where there is a growth in the kidney in the left upper pole. I wish I could have shown you by the pointer, which means that there is a way forward where I will have to be extremely clear in terms of helping out the patient. So that's the stone, which I'm not able to show right now, on the left kidney. And that is such an important aspect of our work. Let me see if I can just point it out. That's it. So that's a stone for which a patient is referred for lithotripsy. A lithotripsy is where we powder stones around and pulverize them. To pulverize that, we got to be very careful that it's not a very hard stone. We do a plain CT KUB, and imagine there is a stone visible here. there is a growth visible here. So this growth, which is in the upper pole, is actually a heterogeneous mass. It possibly is a renal cell carcinoma. This patient has come to a urologist, and I do only ultrasound KUB. I would miss it out. Similarly, you've got a patient on the right side where only doing an ultrasound pelvis would miss out a hydroureteronephrosis before a surgery. Extremely important for us to look into this aspect. For example, a gynecologist colleague in our city where I live and work in had a patient who had an intermittent lower abdominal pain for years. She's a female. She goes to a gynecologist. She also had a reason to go to gynecologist because she had irregular periods. Now, she was evaluated by ultrasound pelvis, and there was nothing major happening out there. But when she one day revealed to me that this pain has not gone, would you like to look at other aspects of it? I said, let's do an ultrasound KUB. I should actually ask for ultrasound abdomen pelvis, but a KUB has been ingrained in the mind of a urologist. And when we do that, we look at that one kidney is missing from the left renal fossa. So that's where a kidney is missing. That should have been, this is the right kidney which is there, and the other kidney is missing. You find that that kidney is sitting here. When we look at that kidney is sitting just behind the bladder out there. What does it mean? When we did ultrasound abdomen and pelvis, we find one kidney down in the pelvis, and there's a big stone sitting inside that. That is the renal stone. You can see that in the pelvis of the stone, which means she required a lap or a robotic pyelolithotomy, and the treatment would have happened long back. But just because she was getting an ultrasound pelvis done all the time, irregular menstrual periods, getting the hormonal management, which was actually doing very well, but her pain had not gone because there was a large stone sitting in a pelvic kidney. So the kidney can be anywhere around, erratically located in various atopic locations, and this atopic location showed that the pain was because of a stone, which was in a pelvic kidney, which got treated only when we looked at ultrasound abdomen pelvis and CT abdomen pelvis. Just to wake you up that this is an important aspect. If somebody had a post-operative detection of hydroureteronephrosis in a gynecological practice, the scare is always that have I kinked the ureter? Has there been a blockage or an obstruction to the ureter post my wonderful vaginal hysterectomy or an abdominal hysterectomy or a laparoscopic hysterectomy? So if there is a patient who has got an abdominal condition, I would always look at now doing an ultrasound abdomen and pelvis and not wake up to a hydroureteronephrosis post a gynecological surgery and have a very important aspect in gynecology today, for which many a times we draw flag because this patient did not have any ureteric obstruction post a gynecological surgery. She only had an ultrasound pelvis and she had a stormy post-operative period. An ultrasound was done and then a CT IVU was done, and you can find that there is a hydroureteronephrosis all the way there on the left side, which means that I had to take a telescope and prove that there is no obstruction. My telescope, a ureteroscope, walked into all the way into kidney, which means that I told the gynecology colleague that this was important, that we should have done a ultrasound abdomen pelvis and proven it. So these were the aspects of looking at non-invasive investigations around, but we're looking at complicated UTI, which women suffer, and UTI is another very important aspect. So paradigm shift can only be done when we look at awareness of this, looking at very focused meets like the one which has been organized today, finally sharing experiences and passing the benefit to patient or the needy who continues to suffer just because we only do urine cultures. We need to wake up to this phenomenon. Let me just touch it a little bit. So recurrent UTI happens to be at least 3 episodes of UTI in the past 12 months or 2 episodes of UTI in the past 6 months. That means the clinical features, diagnostic testing, and the causative organisms are very similar to a single case of UTI. Any case of UTI coming with dysuria, burning, pain, strangury, and frequency urgency syndrome, there could be multiple such episodes happening in a woman to be labeled as a recurrent UTI. Now remember that the additional treatment strategies that you need to look at beyond one UTI are the prevention measures so that you don't get a recurrent UTI. And women, unfortunately, do suffer the recurrence in various phenomena and various percentages as mentioned here. So recommendations are to exclude anatomic or functional abnormalities of the urogenital tract as a cause of recurrent UTI in men and postmenopausal women. There was somebody who is around in 50s, 60s, and 70s, maybe having a meatal stenosis, balanitis erotica, lichen changes happening in the meatus or the introitus because of hormonal conditions. But what about those young ladies coming in 20s to 40s? They are premenopausal. And the yield of most diagnostic procedures is unfortunately very low. It's very low. She's young, her anatomy is good, and that's where there's no obstruction, or the men who get obstructed with prostates and strictures. So very young women coming with recurrent UTI, there are aspects to discuss and just move forward, because that is a huge burden in society. Each of you in this wonderful audience today on an August evening are actually having that important aspect of looking at recurrent UTI built up. So to connect the dots today, the kind of patterns that you see and which patterns we need to treat and look at it is just practical. That means there could be some patients who would get a cure completely because of the kind of therapy we took in. Many of them persist and many of them relapse. Finally, some could have a new kind of a bacteria altogether and be reinfected. So relapse is one where an infecting organism has persisted in the urinary tract despite a good initial response. So imagine somebody has got a pelviureteric junction obstruction or somebody has got a urethral stricture and we sterilize it very well with the needed antibiotic, oral or injectables. Reinfection is an infection after sterilization of the urine. You sterilize the urine completely, the patient is effective, goes home or doesn't come back, but again comes back with another kind of infection, which is because of a new bacterial specimen completely. So whether it's a recurrence or a relapse, to make the differentiation between these two patients, because there's a treatment consequence to each of them. The treatment consequence in relapse is we could not get the infecting organism out of the urinary system because we were only busy treating the bacteria with an antibiotic. But there were reasons around which was causing relapse, and we'll come to that. Experts have an opinion that persistent UTI cause must always be evaluated. In a relapse UTI, the treatment can be given for a longer period of time. That means if we could have taken it longer or would have taken a duration from a therapeutic to a prophylactic range, we could have escaped it. Men getting recurrent UTI could be all this: prostatitis, outflow obstruction with prostate, and complicating factors. I've used a very important terminology called complicating factors. And let's just touch base at some point in time. What are the complicating factors? Unfortunately, women develop recurrence more than men, or there are reasons partly anatomical and partly otherwise. So anatomical factors are the close distance of the urethra from the vagina. And I always keep telling this important aspect because many women don't know how to give a urine sample for culture. As busy gynecologists and urologists may forget to tell them how to give a proper sample. Remember, urinary bladder and urethra have got no bacteria, except that the introitus is soiling the external meatus. The vagina is full of bacteria and the rectum is full of bacteria. Therefore, the introitus may be contaminated with bacteria of different kinds altogether, and there is a healthy commensal intake. But when it happens that the bacteria would invade the urethra beyond the external meatus into the bladder, there's a possibility of infection. Infection does not mean the bacteria in the urinary environment or milieu, but the lumen and beyond. That means the urothelium gets inflamed. That's where the colonization leads to an inflammation, and that inflammatory picture is what causes dysuria by urethritis or pain and suprapubic by cystitis, or a pyelonephritis because the pain is in the renal capsule being stretched by pyelonephritis. Friends, it is important for these ladies or women who come to you and me know that sexual intercourse is something where there could be bacteria after vigorous vaginal activity which could easily touch base the urethra that night. Therefore, sexual hygiene post-coitus, where they wash up the genitals and pass urine before they go to sleep, is an important aspect. So much so, the change in estrogen and genetic abnormalities also are a pattern which bring about recurrence, and we wake up to that phenomenon. So something which I tell premenopausal more frequently is the sexual hygiene, which is important. Their hygiene has to be that deft where they would possibly think of going for namaz 5 times a day, and therefore they're maintaining that hygiene demanded by the religion so that they're keeping it clean. Therefore, that kind of a hygiene where the common area of the introitus where the urethra opens, within which there are no bacteria, but the vagina and rectum are full of bacteria, could actually go and soil and infect possibly urethra and the bladder. So it's, if not treated in time, this actually becomes a difficult scenario where they could be bowled out in life, and the strategies what we make for them is actually lost in cascade. It is important for us, therefore, to wake up to this phenomenon where we go and look at urinary tract as a common area which gets hit because of hospital settings and community settings. And the multi-resistant bacteria, the urogynecology setups like yours and ours are in the front line of superbugs beyond the bugs that we're facing for the last 1 year. Therefore, that you and I combine together to be stronger, I think we need to look at a stronger attitude here and look at recurrent UTI in women to really be abolished. It will not be easy to take this subject unless we know the acute UTI scenario and what do we do. So all women who develop dysuria, burning sensation, urgency, strangery with painful voiding, ineffective voiding, having fever and obstructive voiding, and getting recurrences of these episodes, which I said is acute UTI, getting it again and again, a very important aspect for us to wake up to. That means they would get recurrence of these acute UTI scenarios again. God forbid, we should not have that trouble at all, which means we need to look at this scenario as not coming back again and again. I'd use the word complicated, so let's go to uncomplicated. Patients with normal structure and normal function of genitourinary tract, if they develop a UTI, it could be an acute uncomplicated cystitis, which means that the patients who would have abnormal structure and abnormal function of genitourinary tract will have actually a complicated inflammation of cystitis. So we'll come to that. We also know that women develop uncomplicated UTIs few times a year, and complicated UTIs if there are complicating factors. So I want to talk to you about complicated UTI, where you would partner with your urology teams much stronger from today onwards, is because infection associated with a condition which has got a structural or a functional abnormality of the genitourinary tract, or presence of underlying disease that interferes with the host defense mechanisms, which increases the risk of acquiring infections or failing therapy. Very strong definition in one single sentence. What does it mean? The structural or a functional abnormality. Very, very important. So that's something which we need to know. So structural or functional abnormality, number one. Number two, it interferes with the host defense mechanism. So very commonly, diabetes could be one, or it could be something which could acquire or increase infections more frequently. Or the hygiene could. Let's go to the complicating factors. So ascending UTIs, most commonly, there are susceptible population, as I said, host defense mechanisms in the low. Drug resistance would be common because they've been treated again and again with various drugs, and therefore prolonged therapy has been done. The therapy will still be very prolonged unless they're a very immunosuppressant or hematogenous route. Almost everybody has got an ascending infection. So friends, what are the complicating factors? That's where I wanted to come to. These are the complicating factors. So if you get a woman who develops a UTI in the background of these, which means there are indwelling catheters, indwelling stents in the urinary passage, there is an obstruction to the flow, which could be a pelviureteric junction obstruction, a ureteric obstruction because of papillae or stones, or it could be a bladder outflow obstruction because of bladder neck involvement or stenosis, or a urethral obstruction, that they possibly could get a UTI. Let's leave. There's a male gender which has a complex terminal genitalia and could develop it. Elderly women could develop it. Women who have got renal insufficiency, diabetes mellitus, immunosuppression, psychoureteric reflux, and stones. Pregnancy, which itself is an immunosuppressed situation, and body dysfunction. This large set of patients do develop this trouble around. Let's wake up to that phenomena that complicated UTI is a UTI happening in the presence of an abnormal structure or abnormal defense host mechanism or abnormal function of the urinary tract. So, psychoureteric reflux is an abnormal function. Hypocontractile bladder in elderly women, diabetic patients, or patients who have got spinal issues or neurological diseases is another complicating factor. So remember, when we do a history taking, somebody does a history taking who could be junior to us, we sometimes miss out these important factors when it comes to recurrent UTI. So recurrent UTI, friends, almost always has a past, unless it's a premenopausal woman who maintains a great sanctity of the lower urinary tract by maintaining great hygiene, still getting a UTI, and that's where we'll come to today. Friends, beyond a UTI could be urosepsis, where a UTI from just a UTI uncomplicated to a complicated can go seriously wrong, and patients can develop a urosepsis. Don't forget your patients in gynecology who are diabetics, who have got high residual volumes of urine after avoiding urine, who have got a pelvic floor dysfunction, who have got spinal issues, and who have got neurological issues, could actually land up with complicated UTIs, which could ascend and lead to acute pyelonephritis. And therefore, one needs to be careful that if somebody is having fever, chills, flank pain, probably is quickly ascending into a descent of a deterioration, and one needs to look at that. It is also because of obstructive uropathy of the upper or the lower tracts, apart from an ascending UTI. And therefore, we not go deep into this, but let's look at few women as a case-based example. Look at a very young lady who sees you for umpteen reasons because she wants to see a gynecologist and a urogynecologist. She's 46, she's perimenopausal, and she's getting recurrent UTI with acute episodes. Not a very uncommon scenario. She gets acute treatment, which you do for all acute UTIs, where you ask them to give a proper sample, a midstream and a clean cat specimen the moment she comes and sees you on the first day. You also clinically examine her. There are no vaginal discharge. She looks very healthy and clean down there, but she developed a UTI. It goes on to say that it could be a honeymoon cystitis, or it could be a sexual hygiene related stuff, or it could just be a perimenopausal change happening in that area. You put her on an acute UTI therapy where you give a symptomatic cure, and then you just treat her completely. And then later on, when she's completely settled down, you got culture negative issues, that she has got few episodes of this kind in 2020 and 2021, you put her on a prophylactic dose. But she got a recurrent breakthrough UTI despite all this. And she says, Doc, I'm not related to anything called postcoital. Either I'm not sexually active, or I've got a hygiene which is beyond imagination. So that she has attempted all. She sees a urologist, and we ask for ultrasound, or we ask for a uroflowmetry, and we pick up some reasons around. Therefore, believe a patient when she says there's something wrong. Believe a patient when she says, I'm maintaining it. She says, I maintain a great hygiene. We cannot doubt it. But her ultrasound looks okay. That means there's nothing significant. When we see a uroflowmetry, which is actually, I would say, an ECG of the bladder, that means somebody passes urine in a special toilet where there's a computer attached, and it gives a complete idea about a bladder contraction and the passage opening. And that graph tells us everything. That flow was obstructed. An obstructive flow in a woman at 46 who is getting a recurrent UTI needs to be viewed. And therefore, ultrasound is a lesser denomination compared to uroflowmetry. Uroflowmetry tells the reality about the flow, about the obstruction, whereas ultrasound may not be able to tell about the obstruction. Ultrasound is where a woman would be full bladder and would go to the washroom and empty her bladder in the way she has adjusted herself to. So she has adjusted herself to a way to emptying, and she empties almost everything or nothing. But the pattern in which she passes urine tells us the entire story. So because the uroflow was obstructed, we decided to look at a maturating cystourethrogram and look at that. A maturating cystourethrogram shows that the distal urethra is not visualized. You can only see a proximal urethra, while the distal urethra is being missed, which classically tells us the reality that she is a case of distal urethral stricture. Something where a friend urologist or a gynecologist may sometimes dilate her. A dilatation can only be done for a mucosal stricture, but a stricture as long as that, what is visible here, would actually require a replacement or a urethroplasty. Very important. For example, men develop this kind of a recurrent UTI because the external meatus is soiled, and we do circumcision for them or a frenuloplasty and repair them. Similarly, these women would require a curative intent. They would require a cure where we would look at doing a cure to the lower urinary passage by attempting a therapy forever. A man who develops a recurrent UTI, have a look at that picture, actually has got a stricture and arrow mark. So that's something which is picked up more commonly in men, and he develops a suprapubic cystostomy because we even can't push a catheter. There are times when you can't catheterize a patient, a female patient, you may only have to put possibly a feeding tube or a guide wire and probably dilate it across. Let's look at somebody who gets a post-transplant status chronic UTI and rejection. She gets a recurrent UTI. If she gets a recurrent UTI, when we do a CT scan, the ultrasound has not picked up anything, but we look at, there are gas pockets within the kidney. You can see that. And the whole thing, kidney is calcified. Any kind of antibiotic would not work. She's in chronic rejection. Her creat is already going up. This kidney will have to go. She will be anaphoric. She'll continue to be on dialysis if required or gets a new transplant. But this is going to cause a kind of a pyelonephritis, ascending pyelonephritis. It's already showing gas pockets there in the upper part, the black ones, which means that we got to wake up to it. And these kind of collecting systems with hydrouretronephrosis sometimes need to be removed because then only the health is up. Have a look at somebody else. Recurrent UTI gone completely wrong. She's a female, 52 years young. She has got uncontrolled diabetes. She has got a recurrent UTI, and she presents to you with fever, chills, and right flank pain. If she comes tonight at 8:30, which is 3 minutes before, you would have actually looked at and probably started on antibiotics, injectables, admitted her, given her a symptomatic or supportive therapy. When we did an ultrasound and a CT, we looked at a right hydrouretronephrosis. That means there was a swelling in the kidney. She actually is a case of a papillary necrosis in a background of an acute pyelonephritis. To give you an idea, papillary necrosis is where the renal papillae can break off from the kidney, necrose, and therefore could fall down into the ureter like a stone, which means it could fall down and can block anywhere. It will not be looking like a stone, but will be looking like a papilla lost from the region of the kidney. And this will be managed by some way. We have to take a telescope, remove the papillae. These kind of patients are normally diabetic. They're uncontrolled diabetes. They have a flank pain. You do an ultrasound and you find that there is a hydrouretronephrosis akin to a ureteric colic. This is not very uncommon scenario in diabetic women. Number one, because they normally come very uncontrolled diabetic for a long time. Women don't get the chance to control diabetics in suburban and rural population because their family comes first. And many of these women actually land up with acute severe pyelonephritis. An ascending pyelonephritis can go very wrong if the right injectable therapies are not started, or if recurrent UTI therapy has already been initiated and did not work, while her host factors did not help her out. Remember, such scenarios is where you and I need to look at sorting her out. So we need to take a telescope, go in, a urologist, do a ureteroscopy, remove the papillae, put a DJ stent, drain all the dirty things, and prevent her from a recurrent UTI this time. Because she got a recurrent UTI possibly because she's 52, she's postmenopausal, and she's a diabetic. So there are factors against her. These factors need to be looked at. But we are moving forward and looking at how do we take these patients forward. Diabetic patients deserve to be looked at. Perimenopausal, postmenopausal patients need to be looked at. Remember, diabetic patients whom you look at ultrasound having a high residual volume may not always be easy to empty their bladder only with medicines like tamsulosin. Many of these bladders are actually weak. And remember, diabetic cystopathy is another term which we need to wake up. Like you have diabetic nephropathy, you have diabetic retinopathy, you also have diabetic cystopathy, which means the bladder gradually over long-standing diabetes or diabetes which is uncontrolled could lead to a fibrosis in the bladder very silently, where the bladder loses both the sensations and contraction powers, therefore does not push the urine out. Such women, if you see in the late 50s and 70s, who are getting recurrent UTI and they're long-standing diabetes with control or not control, they deserve possibly a prophylaxis. They deserve a kind of a movement where you use bethanical to empty the bladder. You use a urethral dilatation for a milder changes in the meatus. You also look at tamsulosin and silodosin to help the outlet open up. Recurrent UTIs and diabetes is not uncommon, friends. It is important for us to wake up. If we don't, we'll end up with the last case, 52 years old, who will land up with a pyelonephritis and acute pyelonephritis and papillary necrosis. Because I'm talking about diabetes, I also know that diabetes leads to chronic kidney disease, the commonest reasons of renal failure in the world, and diabetic papillary necrosis, a very important aspect. A microangiopathy and men whose partners you see in infertility, many of these men have got uncontrolled diabetes and they are infertile. Partly they're infertile only because they're not sexually active. They've got microangiopathy and a refractory erectile dysfunction which needs a prosthesis. So diabetes is an important aspect, which means that, friends, there are cautions in complicated UTI. Adjustments to urinary tract is usually common in immunosuppressed states. One of them is diabetes. Let's not treat dysuria or burning sensation very empirically only by urispas and cetal. We need to look at dysuria with 13 reasons. All documented UTI should be taken to culture negative status if possible, and all recurrent UTIs always have a cause. Example could be an obstruction. Therefore, we're waking up that we need to give antibiotics, and do we have to give antibiotics all the time, escalate and de-escalate? Or there could be other UTI regimens and close follow-ups for my gynecology colleagues in the country. And that's where I'm waking up to this important aspect that the main pathogenic causes of recurrent UTI, though is E. coli, the other bacteria also do cause this, which means there are bacterial load which actually gets into the urinary passage. There are other kinds of bacteria which cause other kinds of UTI. So wake up to it. For example, Klebsiella and group B streptococci cause diabetes infection more in diabetic people. So if you have group B streptococci and Klebsiella causing UTIs, suspected diabetes mellitus. If you have got pseudomonas more commonly, then it's a region of foreign bodies or chronic catheters. You could be having a suprapubic catheter, you could be having a chronic indwelling catheter or a chronic indwelling urethral stent. Proteus mirabilis is a common uropathogen in patients with indwelling catheters, spinal cord injuries, and abnormalities in the urinary tract. So imagine there's another scenario happening here. Now, as I said, this is a factor known to gynecologists so well. Number of host factors appear to predispose otherwise healthy young women to recurrent UTIs, healthy young women, which means that there are changes happening in the local pH and cervicovaginal antibody changes in the vagina, greater adherence to uropathogenic bacteria to the urothelium, and finally pelvic anatomic differences such as shorter urethra to vaginal distances. Therefore, the host factors also predispose very healthy women from getting into recurrent UTIs. And therefore, this is a very important evidence that today we have, friends, where we looked at ways of escaping a long-term antibiotic. Let's get to the postmenopausal women and learn from the postmenopausal women that estrogen loss at menopause results in thinning of the vaginal epithelium, and therefore there's decreased glycogen. Not much glycogen there. The resulting environment is hostile to the normal bacteria or the good bacteria, the lactobacilli, and their numbers therefore gradually decrease. The vaginal pH therefore increases, and there's an increased propensity of colonization by the uropathogens. So that's a postmenopausal state, sadly, which happens in late 40s, early 50s, and goes on till 70s, 80s. The changes are cascade. They continue to happen around. So with estrogen loss, thinning of the vaginal epithelium, loss of glycogen, loss of lactobacilli, acidic pH, and increased propensity of uropathogens, comes an issue where the UTI becomes more common. There are investigations that all of you do. All recurrent women with recurrent UTI should undergo a physical examination to evaluate urogenital anatomy, estrogenization of the vaginal tissues, and to detect the prolapse. Now, we need to look at post-water CD, which is a common measurement that you and I do. But diabetes screening should not be missed out in patients who have got family history and who have got high residual volume and who are not emptying or who are obese, where there is that metabolic syndrome playing into the games around and causing UTI. Most women do not require extensive urological investigations. Therefore, I salute each of you who actually does a workup on UTIs as gynecologists and urogynecologists. However, women who suffer infection with organisms which are not common causes of UTI, as I said, Proteus, Pseudomonas, Enterobacter, Klebsiella, which you keep looking at the cultures of, remember, proper urine samples, which means midstream and a clean cat specimen, then only it works for your favor. Now, they would benefit from imaging studies of upper urinary tract, maybe looking at a CT IVU, looking at CT scans, identifying all that and looking at a cystoscopy and identifying more. So these are the patients who require an extensive kind of workup, who have been stone formers, who have stones, there is a hydroureteronephrosis, there is a postmenopausal change that requires a calibration and dilatation. Remember, if women have got hematuria after resolution of their UTI, then they would require a complete urological workup. Women also have been smokers in their lifetime, and there could be a reason for microscopic hematuria resulting from a possibly carcinoma in situ in the bladder and the urothelium. Although empirical therapy based on symptoms is generally accurate and cost effective, women who are felt to be in the early stages of the problem with recurrent UTI should have documented cultures. That means you documented that the cultures are negative. That means UTI is not only about the bacteria in the urine, but the changes happening in the urothelium. And therefore, urine culture not only serves as a gold standard for diagnostic accuracy, but also provides very specific information about the kind of uropathogen antibiotic susceptibility. And let's respect that very much. I'm not going deep into it, but remember 10 to the power 5 is what you look at. But 10 to the power 3, even in a susceptible patient or in a patient with clinical scenario, is still taken a very important specificity and sensitivity and regarded it to be converting into a culture negative status. Remember, all the time while you're treating it, identify that there are no complicating factors all the way from stones, obstruction, functionality, diabetes mellitus, reflux, etc. In women with 10 to the power 3 colony counts, as I said, it could still be considered sufficient to document infection without compromising specificity. And we look at always a clean catch and a midstream urine specimen, friends. Sometimes in a busy practice, we forget to tell them. It could be early morning 6 o'clock or evening 4 o'clock, but we need to look at it. If somebody has got more than 20 epithelial cells in a urine specimen, probably discard it because it's more of contamination by vaginal secretion. Therefore, it's not a proper sample. It's very important for us to look into that. And then there is the bacteria which reduce nitrates to nitrites. And therefore, the use of urine dipstick analysis itself is a very important aspect because the dipstick turns the complete color, which gives you an idea that there's an infection for you to start early by the time the culture report comes. A negative result does not rule out an infection. Therefore, you are belonging so much to clinical evaluation by a patient. Remember, some bacteria such as Staphylococcus saprophyticus, they lack enzymes to reduce nitrates. And if the urine does not be present in the bladder for at least 4 hours, they may not have sufficient time for the reaction to occur, which means that some of these ladies who have a grossly overactive bladder resulting from an urgency frequency as a result of a severe UTI, there's a possibility that we may miss out on infection-related stuff in these patients. So let's move forward and look at the treatment aspect. And you look at treatment, you do it so well. You look at all these aspects which could cause recurrent UTIs in a younger woman, and therefore looking at the hygiene, looking at the sexual hygiene, and making them more well-informed of maintaining hygiene in the introital area is an important aspect. You also work on antibiotic prophylaxis. You work on that in a very big way. Sometimes the prophylaxis could last a few weeks, and you identify that this is a recurrent UTI. It may last for 3 to 6 months, and the patients who have been in community for a longer period of time. But those were yesteryears when we had only few antibiotics as prophylaxis. You use nitrofurantoin and you use trimethoprim alone. You should know that Baxtol or trimethoprim is a wonderful antibiotic, apart from nitrofurantoin, which is normally given as 100 milligrams once at night, or Baxtol, which is only trimethoprim without the sulfa, is given 200 milligrams once at night. It could be given anything between 3 weeks to 3 months and beyond to prevent and curb the chances of UTI, sadly, because this could happen. Let me also tell you that women have hypospadias, which means some of the women may actually be passing urine into the vagina rather than into the exterior. The urethral opening may not be exactly parallel to the vagina, but maybe opening near the introitus, which means near the vagina. And therefore, women actually have their introitus really soiled, where the urethra is opening into the anterovaginal wall. So don't forget, when you examine a woman, also look at the location of the urethral meatus, because there's a surgery called urethral opening translocation. We've done in at least 3 cases in 24 years. I remember, and a few of my friends have taken up that subject, where the urethra was opening into the vaginal wall, not exactly anterior vaginal wall completely, but somewhere in the vaginal wall as a hypospadic urethra. And all effective measures had failed. During a cystoscopy, we picked up that the opening was not right. The opening had to be brought away from the vagina, which is a storehouse of bacteria, which is obviously changing. And these patients did very well when we did a situation of a hypospadic female urethra, change it into a new location, which is a normal female urethral location, just below the level of the clitoris. So very important for look as prophylaxis, but identify all the factors of a recurrent UTI or a complicated UTI. So use of the antibiotic selection for prophylaxis is a result of a lot of things. It's just not nitrofurantoin or Baxter. You look at the effects and the side effects of short and long standing, and sometimes use your urology colleagues to identify the causes. Antibiotic prophylaxis, as I said, could be anything between 6 months to even few years if required, but that era is gradually going away. That era is gradually going away because there are many other ways. And one of the ways, as I talked in the early part, is looking at post-coital prophylaxis or a sexual hygiene, which is such an important aspect. Looking at these patients, preventing themselves from getting UTIs is an important aspect in a younger woman. Otherwise, sex becomes a pain for them. We also know that you treat these patients with estrogen in the postmenopausal women. And there's a huge amount of randomized controlled trials and Cochrane review, which talks about evidence from Cochrane review, talks that there is 0.5 milligram of estradiol cream every night for the first 2 weeks, and then twice weekly for the 8 weeks. It's good enough alone when there are no factors available in a perimenopausal woman or postmenopausal to decrease recurrent UTI. That's been effective. There's been a pattern practice of the urologists, urogynecological aspect. It works similarly to the mechanism which we had reversed as a result of menopause, where there is a reappearance of vaginal lactobacilli with decrease in the vaginal pH. Lactobacilli prevents the overgrowth or colonization of Enterobacteriaceae or the uropathogens in the vagina, and therefore reduce the recurrence of UTIs. They can do this much, but they can only do this much, which is a reversal aspect. Cranberries have only worked to an aspect, not beyond that. They work as anti-adherence properties. I will not go deep into cranberries in that aspect around, and move on these slides and come to a new aspect altogether, which means that we are looking at D-mannose, which is another important aspect, which probably has been effective only to some level. Combined cranberry and D-mannose is available as tract-free XT, something which I have used in patients who have actually got an effect of the whole therapy around. Yeah, so I need to look at how to take it problem to the next level, and that's where we are with you looking at how to take it forward. That means the D-mannose also worked as competitive inhibitor apart from the cranberry, and both of them competitively inhibit bacterial growth, P. pili antigen anticipation, and therefore mechanism of overgrowth of bacteria in the urothelium, which could be urethra or the bacteria. As a result of a combination of both, which is cranberry and D-mannose, we have been able to qualify and probably manage this to very high levels. I've been using tract-free XT for probably now n number of years. This has been effective in majority of patients. To me, the dosage has been twice daily in the early part, and then a prophylactic dose of once for approximately 3 months. And that probably has helped in majority of patients who had no other reasons to. But we are growing beyond it. There is a small subset of patients who actually have beyond tract-free XT's wonderful work that you and I have done around, which means cranberry and D-mannose, gone to the next level where they had a requirement, and that requirement is what I'm talking today to you. I've been using this for the last 4.5 years right now, and I confess that it had to happen, which means we were all searching for ideal probiotic, and I thank Zydus and many of my colleague gynecologists who have shown the path to us for us to have picked up, which means for an organism to be probiotic, it must essentially be non-pathogenic. It should be generally regarded as a safe one, which can be taken up without a trouble, like the antibiotics. And we're looking at tolerating the pH of it, and to tolerate the immune system should not result in formation of antibodies, and such that the organisms does not confer antibiotic resistance through horizontal transfer, which means that ideal probiotic was always surge and surge and surge till somebody got it. It means that in recent 5 years, use of probiotics per se in the abdominal segment or in gastroenterology was already very high. They were looking at alternate and expensive and natural remedies to restore and maintain health. And there are two strains, Lactobacillus reiteri and Lactobacillus rhamnosus. Now, they appear to be effective in colonizing and preventing the intestines and urogenital tract, respectively, against antimicrobial and some microbial infection, which means they work as antimicrobials without having a property of the requirement which we always use prophylaxis antibiotic for a long time. So there are that 70 to 90% patients who were in that era treated with nitrofurantoin, with Baxtol, their numbers came down. Many of these patients were then switched over to a lesser dose of antibiotic requirement and more of cranberry and D-mannose like the tract-free XT. BD dose for the first 6 to 12 weeks and thereafter OD dose for the next 3 months. They were effective. But then there was a small subset of patients who would still not be effective. That's where, while the search was on, it was important for us to wake up to the phenomena of identifying a proper probiotic. And thanks there, we have got a probiotic which works on various aspects, which means there are the strains which are effective as barriers, which are effective as colonization resistance, and effective as immune enhancement effect. We've got all the three moving around, helping us out to take it forward. So let's give you a little idea of what does bacteria, lactobacillus rhamnosus, and reuteri do. Once they reach the site, they multiply and form a dense layer of epithelium along the site of mucosa. If your questions coming around, I would answer most of them and I would take it forward. But I want to give you this peace of mind because it's such an important aspect in our prevention attitude to treatment over n number of years. So as a result of the barrier effect, it blocks the pathogens to translocate to other tissues around the site to create large biofilms or sheets of good bacteria that form the barrier on the vaginal and bladder walls. Are you and I not aware that we were trying this by the estrogen cream? Now that we have a blocking effect, because there is that large biofilm which is not visible to you, sheet of good bacteria coming in. And that's how a barrier effect happening in the vaginal wall and bacteria. The colonization resistance is about antimicrobial substances being produced, which inhibit the growth and attachment of uropathogens to the uroepithelial cells, and therefore balancing the vaginal pH. That's the resistance pattern of probiotic. And finally, immune enhancement effects of probiotics, regulating the localized host innate mechanism by its local productions. In such a way, it lowers the risk of infection. Friends, if you have been using it, great. If you're not been using it, it's worthy using around the way I have been using it for some time. What has it helped me with? Lactobacillus rhamnosus and reuteri, which comes in that capsular form, available in that specific packs that has been effective in terms of storage, is effective means of regulating the fluctuating vaginal flora that happens in a perimenopausal age group, and therefore lowers the risk of infection. Many of them may not require to see you in your busy practice because you only restored them to such limits. They are something which colonize the vagina when administered orally. So how does it happen? You took orally and the colonization happened vaginally. It's after a decade plus of research that probably Zydus brought it forward to us. And to me, it actually is a great arm in using these patients around. Probably those first 2 weeks are important. We use it also for acute UTI, which I'll talk to you. The first 2 weeks are extremely important. So let's get to the concept. The concept of delivering lactobacilli orally to repopulate the vagina was as long as 20 years ago. And based on the question, if urogenital pathogens can do this, why cannot lactobacilli? So an oral dose of 1 billion organisms per day was found to maintain a lactobacilli environment of dominated vaginal presence. And that's what you wanted. You always wanted women should never grow old. Women on the women's day should still feel younger and better. That means they never get a UTI and come and see you and me for that, which means an advantage of the oral approach may be the ability of lactobacilli to reduce the transfer of the yeast and the pathogenic bacteria from the rectum to the vagina, which could potentially lower the risk of infection. It happened dramatically when we looked at the UPMT technology. What is that? It is a unique polysaccharide matrix technology where once you swallow the capsule, which now I do it twice a day for my female patients to start with, and I go it anything between 3 to 6 months. I give them a gap of anything between 1 to 3 months and watch how they have done. Intermitting it with a lesser activity on the tract 4 pre-extreme required. We look at the gelatin of the capsule once it goes to a stomach in the acidic pH, dissolves. It dissolves, and the polysaccharide matrix, which I said is unique polysaccharide matrix technology, it rehydrates to form the gel at the surface. Once that has happened, the gel then dissolves in the duodenum, which is now from a very acidic pH to a lesser acidic pH, getting into a basic pH. That's where Lactobacillus rhamnosus and reuteri are now released into the bowel. So from a capsular form, rehydration and the release, as this goes on, watch out. It then gets into the bowel, colonizes and releases into the bowel. It then passes through a digestive mechanism and ascends via the perineum into the vagina. That means the colonization of the vagina is almost complete. Yeah. As this is happening, I need to look at what are the indications that my gynecology friends use it for. I don't get to use for all these indications, but that you examine and look at bacterial vaginosis, yeast vaginosis, urinary tract infections and its complications, preventing all these three, and looking at some patients before in vitro fertilization procedures who should not get a UTI. I mean, there's a large subset of patients who deserve to be treated on this aspect. And friends, recurrent UTI actually can be managed. To me, this important Lactobacillus rhamnosus and reuteri, having used for the first 3 months BD, gone into an OD dose, looked at them for the first 6 months, more so for the perimenopausal and postmenopausal women, where I had no answers but to give them only antibiotic prophylaxis for so long. It was very different. Now today in 2021 that we have such huge body of evidence both in India and abroad, I think I've looked at antibiotics or prophylaxis for a shorter while. I looked at TRACFE-XT for a longer while, and I've added that onto FemBio for longer. Remember also, I talked to you regarding the evidence that it takes 2 weeks to be completely active. For women is getting actually a recurrent UTI. While I treat the active UTI with Cetal and with UriSpas and with Meftal and antibiotic culture activity so that we get them sorted out in that aspect. We also look at 2 weeks later, she should not develop another trouble. 2 weeks later, I want to, a perimenopausal or a post-menopausal woman, colonize her vagina in time. You already examine her on day 1. You looked at her urethra is sore, she is in discomfort. You possibly would sound something preventing, which works 2 weeks later. I think that important aspect of treating a UTI recurrent in a perimenopausal woman, we got the answer. And I'm very happy that today with TRACFE-XT, with nitrofurantoin or with Baxdrol, the trimethoprim, and finally with FemBio, be able to work into that 90% of UTIs in women, which are not actually obstructive, like I showed you a stricture urethra or a metal stenosis or a weak bladder not able to contract. So friends, recurrent UTI is your domain. Giving the subject back to you was important today on a Wednesday evening, where UTI, recurrent UTI and complicated UTI are finally treatable. It's not a trivia anymore. It's probably basic evaluation, examining, talking, identifying them, picking up the risk factors, very important for them, and why not cure them completely and start 2 weeks later effect today to give them a prophylaxis. So many of my patients who are the postmenopausal and perimenopausal age group, while we start them on all these acute UTI scenario, we put them silently into FemBio. We look at them later on to TRACFE-XT. We look at them in 2 weeks' time, effectively enough, engaging their lactobacilli now to remove the uropathogens, while you will also start them on estrogens as a part and parcel of their therapy. In doing so, you're actually getting a patient involved in a therapy. I did talk to you the first slide. While I follow the motto, every life matters, we're also looking at improving the quality of life of these individuals who are not able to take a suburban train from Dombivli all the way to UTI or Churchgate because they have UTI, they've got urgency frequency, they've got dysfunction, and that's something which we need to sort out. Very important. So friends, the future is about awareness, asking them to give a proper, clean, midstream clean cat specimen, very important. Number 2, maintaining the hygiene, which is sexual hygiene, and the female hygiene, sadly, because of the anatomy that God gave females compared to men. Prophylaxis in at-risk patients. The patients who are at risk are known to us: elderly women, diabetic women, obstructed women, functionally spinal diseases women, women who have got anything which is neurological. Idle probiotic is here, which has been supported so well in the era before by Cranberry D Manos, the TRACFE-XT. The complicating factors identification is also your job, because women always go to effective doctors who are gynecologists who actually have masters in pelvis and perineum. So while you look at all these important surgical aspects, you also go to identify those important patients. And that's where your urologist is your partner in pelvis or friendly neighbor who helps you to identify and take this therapy of a stricture urethra or a metal stenosis or a vesicoaortic reflux, where he injects or probably does that and takes you forward to the highest possible level. Let me not forget that female urethral strictures, being a reconstructive urologist, I did present this and operate even in Patna, where we had female urethral strictures and where we looked at improving this. We looked at operating them and getting the urethral strictures treated. And this is something which FemBio and TRACFE-XT may not be able to do. They may only sterilize. So look at, this was the masterclass 1 where you had looked at treating them around. Look at the female urethra. Female urethra is only a 4 centimeter challenge. It's looking at a horseshoe-shaped sphincter which is surrounding, and therefore both urologists and gynecologists are afraid about that. But don't forget that it shares a wall with the vagina ventrally and the clitoris dorsally, which means that you have a transitional epithelium for a while and then there's a stratified squamous epithelium. This transition of epithelium is also a host defense mechanism which undergoes complete resistance. A female urethra can also have a stricture urethra, like the guide has shown you, and we need to look into that. Now, this woman has a bladder neck which is completely intact. You can see the urethra there below the bladder, which is visible well to you. And that urethra is fine, but the urethra below that is not a normal urethra. That urethra, sadly, is a urethra which needs to be looked into. So as a result of this, we need to probably not do dilatations, which has been going on in this woman for years together. She has got a BXO change. Her matrix looks indurated to you. That's where you will take up a urethroplasty with your urologist colleague. And patients do come in from all over the country and the world after having years or decades of urethral dilatation, and the whole thing is a BXO hard stricture. The one here, look at it, is a long-standing distal and bulbar mid-urethral stricture with ears in the bladder. So that's something which you need to wake up to. And these are the MCUs which I'm worried about. Dilemmas for the patient is they live with the entity, they've got recurrent UTI, minimal invasive approach, which my urology colleagues would continue doing is dilatation. But sadly, we need to have the expertise, the method of repair. We don't have a sphincteric injury in such cases, and they get it. I've done close to 96 female urethral strictures compared to 2,500 male urethral strictures. Female urethral strictures are not so uncommon. The world is waking up to female urethral strictures where we have wrongly been treating them with dilatation all the time. Dilatation is not off. Dilatation are for the mucosal strictures. For very short segment strictures where we could calibrate and stabilize them. But for indurated strictures, segmental strictures, strictures which are long, strictures which have been result as a result of trauma are not to be treated around. They are considered rare. 4 to 14% of female bladder outflow obstruction in data 20 years ago. Now we know that trauma, iatrogenic, urethral diverticular, fistula, incontinence, all these are patients, and inappropriate treatment of lower urinary tract symptom with urethral dilatation emerges as the leading cause. So never dilate urethra, just hoping that you actually get an answer. Just giving you an example, poor flow, recurrent UTI, urethral pain, hematuria is something we need to wake up to. These patients actually had urethral stricture. So somebody has a poor flow, we start giving them tamsulosin, both males and females, sadly, or those who have got a diabetic cystopathy, we start giving them bethanechol. Recurrent UTIs, we treat them with everything. Urethral pain, we probably give them painkillers and tell them sometimes they're psychotic. Hematuria, we thought is always because of stones, and there were no stones and no tumors, and some had OAB and SUI. But unfortunately, all of them in that small subgroup of 26 patients were complaining of something which possibly was not loud enough for us to pick up till we picked up stricture urethra. So it's important that the stricture segment needs to be looked into. I will leave this subject and move forward because there's so much of evidence. You have a female urethral stricture. Some of my colleagues, including me, are deeply involved in that kind of a work, which is evidence and experience of treating patients separately and taking it forward. So I'll just leave that subject and move forward to possibly identifying that stricture management is not about dilatation all the time. Now we look into something which you deal around is incontinence in short. And let me not forget that there are two kinds of things. So let me give you two cases. One is a young woman, only 27, and she talks about my boyfriend and I don't go out very often because of my problem, doc. If we go out for a departmental store, the first thing I look for is a toilet. If I don't get one, I leave the store. This is how serious my problem is. What does it mean? This case study from Patna is about a woman who saw us n number of years ago, and she was so young. And she was actually a case where she cannot control urine. Let's look at somebody little elderly. From 27, let's move to 67. Let's look at Mrs. Rao. Mrs. Rao came and they said, having this problem is really bothersome. For example, I totally avoid taking the bus even in Mumbai or in Chennai or in Patna. The reason is I can't ask the driver to stop, like a suburban train running from Dombivli to Churchgate cannot stop. And these women either wear a dark pair of clothes or wear extra paddings or don't drink water or possibly get down at a Andheri station, pass urine and go. What is the plight of such women who actually go to the entity where they can't hold urine? Life comes to a complete circle where women go to this more commonly than men. It also increases with age. And therefore, we are looking at women who are getting gross frequency of urination. For example, they get 14 times a day urination, and they're still very young, 44. They get occasional nocturia, they have some dyspareunia, they've got regular menstrual periods, and they're treated as recurrent UTI over the past few years by your colleagues with no relief. But their main problem, apart from dyspareunia and some irregular menstrual periods, is not UTI. It actually is a gross frequency of urination, which probably has been missed out. Let's look at somebody who's only 29. She complains of gross urgency. Her main complaint is urgency. Doctor, it's precipitancy. If I feel, I will have to pass urine there. She's only so young as 29, and women do come and tell us. And she's 1 year in progress. There's a compelling desire. So remember, urgency in overactive bladder is the most compelling issue. You can't control. You will have to leak wherever you are in, or you are in deep trouble. Nights are so good, I just go to sleep. But days I pass so frequently, I can't hold. Doctor, I see my gynecologist because I've got gross irregular periods and I've got a PCOD. My urine routine and cultures are normal. She sees you for the first time tomorrow, and remember, she doesn't have a UTI. Which means if she has gross urgency, urge incontinence, or a gross frequency of urination, then she's somebody else. As simple as that. Let's wake up to this, which is extremely important. Let's look at somebody from this to the next level. She is 54 and she has a postmenopausal lady. She has got urge incontinence 8 to 12 times a week. That's sad. 8 to 12 times a week, she describes as a precipitancy which she cannot hold. Classically, if she cannot hold and she leaks urine out, she must be wearing a diaper. At Bengaluru airport 1 year ago in first week of March before the lockdown and COVID came in, she actually leaked urine. And she has been treated for DUB because she had one and menorrhagia by a gynecologist. Perhaps she did not speak up, or probably we as gynecologists did not ask, do you have any urinary and sexual complaints? One question asked, do you have urinary and sexual complaints? Women will wake up. They've got so much that they don't know whom to speak to. So sometimes they say doctor must ask, and sometimes we say a patient must say. And in that, there's a wall where we miss it. Her records show that there's repeat urine evaluation and the urine is completely normal, which sincerely means that things are looking like our gynecology colleagues today have looked at 3 patients, just going back to them. Gross frequency of urination 12 to 14 times a day and nights are okay. That's as a young lady. Somebody has got gross urgency, precipitancy, and it's progressive. And somebody has got a gross urge incontinence, which means that these patients are different. They are not UTIs. So how do they live their life? They live their life with diapers, drinking less water, as I told you, less beverages, wearing dark clothes, else they would leak. Don't take city bus and suburban railways like in Mumbai, Chennai, and Delhi. They are fear of UTIs from public toilets. They don't drink water and don't pass in public toilets. All of them, sadly, are wrong. The public toilets don't cause UTI. The public toilets are not being used by women. The bacteria is not waiting in a public toilet to jump into the vagina and the urethra. You have got a friendly neighborhood called vagina and the rectum. The bacteria are already there. You're holding urine in a public place. Your undergarments are getting wet. And therefore, it becomes a nice, easy tool for bacteria to walk up that wet introitus. Remember, women need to change undergarment in such situations of getting recurrent UTI. The hygiene demand is obviously more. When they are going to a public toilet, the urinary system, the whole introitus is already wet. They're already overstretched and strained. The bacteria are already moving from the introitus, vagina, and the rectum into the urethra and into the bladder and giving them an asymptomatic cystitis. Something which happens when women actually leave Lonavala and actually come to Bombay. There's only one toilet. The women have to queue up around. So they had a great time there for 5-7 days in Lonavala, no UTIs. They are all the way coming there and suddenly they want to pass urine. And there's only one toilet in the midway. The women are queued up and it's so sad to see that. Government needs to wake up to female toilets in the Women's Day today. For women need to be able to pass urine anywhere. And we all combine together say toilets don't cause UTIs. Only when you postpone your urination to such levels, you have already caused your diapers or your possibly undergarments to get wet. It works as a good ladder for bacteria to walk into the urethra, which otherwise was maintained so wet and dry when you were in your holiday at Lonavala. So looking at fear of UTIs in public toilets should go away completely. Overactive bladder in females through a very dignified gynecological audience is important. It's important to know the tips and tricks because 15 to 43% of Indians suffer from overactive bladder. And unfortunately, it's not reported. Women came to you for menorrhagia, DUB, and even hysterectomy. They never told you because you never asked, or they were shy to tell. They would say, we'll tell somebody else. It's underreported and therefore underdiagnosed by urologists and gynecologists, understudied and undertreated. Sad story, but these to be waken up. The perspectives for both women and men, elderly and young, are different. They think it's a part of aging in every night of life. They think it's not too severe enough to treat treatment or it's too embarrassing for us to look at how to take it forward. Treatment may not help because my neighbor and my auntie did not help and the doctor would put me on long-term therapy. It's time for us to wake up to see a urologist or a gynecologist or a urogynecologist today in making or those who are already there. A very focused clinic would help such patients out of agony. It's important for us to wake up to that. Therefore, friends, overactive bladder in gynecologists is an important perspective. From recurrent UTI, I have moved to this because awareness creation to the society. One, women need to wake up and not just go over the counter and pick up drugs. They need to go to our fraternity of gynecologists, urologists, and urogynecologists. And we as colleagues in this important aspect should be really armed A to Z in overactive bladder, which means then we will be able to give A to A and B to B and Z to Z. That means we will have to be able to give a right approach to a right patient. Remember, 53% of Asian women close to 20 years ago in 2001 study showed symptoms of overactive bladder. Most commonly was urgency. I did talk to you. So let's not forget, one of us or everybody of us at some point will have either urgency, frequency, and urge incontinence. Give us as medical fraternity. Sadly, we don't seek treatment as much as they don't seek treatment. They only go, 21% of them go to a urologist or a gynecologist. So to me, it is an important aspect. Whom do Asian women consult? Everybody except a specialist. And who is a specialist? You. So in red, if so many people are specialists, all of them should have gone to a specialist called gynecologist. That's where women would have actually got the right therapy in right time. They could have got a therapy of overactive bladder. Let me just come to it. We never had that important thought about creating an incontinence clinic. as gynecologists, as urologists. We never got into complete armamentarium beyond a stress incontinence in women. You should know everything from a psychovaginal fistula to a ureterovaginal fistula to an overactive bladder. I think we had known everything. We could have been better. We should have given priority to this and an awareness of this, which we are giving today, because you could choose an incontinence day. It could be Saturday, could be a lighter day. Choose an incontinence day, or choose the last week of the month as incontinence week, or probably choose one of the monsoon month as incontinence month. The communication levels to a society with the buzz that it happens in your clinic, which talks so much about mother and child health, could also add this. If you put nocturia, if you put bedwetting, if you put overactive bladder, urgency, frequency, women will say, oh, this is my doctor. I need not go anywhere else. My gynecologist is my entire doctor. And therefore, the larger subset of challenge here is we have treated them to a lesser dose of medication. That lesser dose of medication possibly was not the right dose. It always was important for us to wake up and identify that these patients deserve the right therapy. So to us, India does not live only in Mumbai, Chennai, Kolkata, and Madras, and Bangalore and Delhi. India lives in much smaller and two-tier cities and towns, women who don't get to see. And I don't get to see all my colleagues in gynecology all the time till the lockdown opens up and we have the master classes again. But we look forward to elderly women and women who the population with lesser access. Unfortunately, UTI is not being told, not being made aware. And that is a large subset of challenge for me and you, friends, to wake up to it. As I said, this needs and belongs to you completely. And therefore, because it is important for you to innovate. For all the gynecologists today who would from tomorrow be urogynecologists stronger and better, it is important to wake up incontinence is also your domain as much as recurrent UTI. That teams you better with your urologist in your cities and your clinics. We're setting up an incontinence clinic is thinking out of the box. Maybe your urologist also will get enthused on this. Maybe incontinence day, incontinence week, incontinence month, and teaming up and some juniors in your rank could actually help it up. That's how urogynecology was born, which as urologists, we call it as female urology. It's very important for us to wake up to that. Identifying the right patient and treating them rightly is important. And therefore, our overactive bladder aspect, in very short, is about this. Remember, overactive bladder is a problem of the storage phase. The bladder cannot store urine. And therefore, while the sensations are happening, bladder leaks urine. Compared to the emptying phase, where you have got an issue of underactive bladder. So wake up to phenomena. Overactive bladder is about storage phase problem where the urine cannot be stored and the bladder contracts and leaks urine out. The emptying phase mechanism, if going wrong and the bladder cannot empty, that means the bladder is an underactive or a hypocontractile bladder. So two diseases you're picking up in this slide, underactive bladder and overactive bladder. Underactive bladder, sadly, is underactive forever. If my hairs turn gray today, they will never turn black again. If I'm 51 today, I'll be 61 10 years later. So change has happened. It cannot be reversed. But yes, ethanical in the right dose has been partly effective in such situations. Similarly, for the overactive bladder, there's a whole plethora of drugs which you need to look into because the balance has gone wrong between contraction and relaxation. That has suddenly gone wrong and we need to help, which means involuntary contractions of the tubes are happening during the filling phase. As I said, the storage phase brings about overactive bladder. And it's all about urgency, urge incontinence, increased diurnal frequency, and sometimes nocturia and post-void dribble. Entire aspect of this sudden compelling desire, precipitancy, not able to control, wearing diapers because I can't control is an overactive bladder, which women go through. And they go through the agony, which translates into their life, and the quality of life is miserable because the impact is huge. Sudden urge in the toilet, standing at Bangalore airport at 44 years and leaking urine is something which is so sad. We need to wake up to that phenomenon. The whole aspect of women's life and the quality of life, if she is overactive bladder, is a disaster. Right from the sexual and social life to her psychological aspects that she goes through 20 times a day, physically that she's wet and occupation financially, she cannot drink water, or if she's working in a place like a bank, she's in deep trouble. So overactive bladder is a disabling condition, impacts families, careers, profound implications, and it's important for us to wake up to women who go through it more commonly than men, wake up to elderly who go more frequently with that. But remember here, an important catch, please, and remember that overactivity of bladder also happens in UTI. I said a woman with UTI is awake the whole night, sitting on a commode, more so in honeymoon cystitis, having urgency. That's because the bladder has got inflamed. So inflammation of the bladder can bring about overactivity of the bladder. Bladder outflow obstruction. If there's a bladder outflow obstruction by bladder neck stenosis or a metal stenosis or a stricture urethra, any of them which causes obstruction to the bladder, women will have an overactive bladder. The bladder is secondarily contracting to bring about issues. And then you have interstitial cystitis bladder pain syndrome, where the bladder is unfortunately going through pancystitis and the bladder is in a phase of contraction, where you have a forced contraction, a forced frequency, you go more earlier, sadly, because the contractions are immense. And finally, you have got idiopathic overactive bladder, which can happen to any of us, including you and me in the audience. The bladder just contracts and there's no reason. And we need to mellow the bladder. That kind of patients are common. You get this idiopathic overactive bladder who says, everything is good, doc, but just that we are rushing everywhere. We can't drink water when we are out. And these kind of patients are men and women. Women suffer more in the youngsters. Men suffer more when they are elderly, but women and men both have increased amount of overactive bladder when they are in their 50s, 60s, 70s, and 80s. So don't forget your postmenopausal women, when they come and tell you about urgency, frequency, and urge incontinence, like those women who came in earlier days, which you saw in those 3 cases, important to wake up and look at those guidelines. Important to know that the post-word residue should be normal. You're not doing any investigation beyond it. If you can just clinically examine them, look at this, no reason of obstruction causing an overactive bladder, and you don't have the urine analysis showing a UTI, which could also cause a temporary overactive bladder, and the post-word residue is not huge, which parallels that there is no bladder outflow obstruction. Obviously, the best is to see a uroflowmetry, like I showed you. The questionnaires will help. So there's a bladder diary, which is so important, a voiding diary, which tells what are the times that she passes urine more. Is it a nocturia where she gets up multiple times? Is it that she takes too much of tea, coffee, cola, and she's on diuretics, which causes more amount of bladder filling and therefore overactivity? And in only those patients who are refractory, or there are a subset of patients, will there be a cystoscopy and a urodynamics and workup. Otherwise, uncomplicated patients don't need a workup, because their goals are as good as your and my goals. Their goals are decrease the urge incontinence, decrease the urgency, frequency, and issues. Treatment compliance has to be told to them, because long term will only happen that we can continue doing this and look at how to meet the patient expectations. Very important, friends. Evaluation of the bladder, with the bladder having a mind of its own. It relaxes and contracts and serves 2 functions of relaxing and contracting. Ultrasound is what you do. Uroflowmetry is what I requested. Urodynamics is something which we need to be aware of. And there are specific indications which is out of the purview today. And let's not forget that midstream clean cat specimen with proper urine culture sensitivity is something very, very important. So waking up to these phenomena and giving you an understanding that these aspects need to be woken up. So if you give not a right sample, we basically are treating a contaminated specimen, and that will not work in our favor. So let's wake up to the phenomena that we will tell our patients that please give a proper midstream and a clean cat specimen after cleaning up the introitus. And that is important, because otherwise they develop a recurrent UTI. They prevent a recurrent UTI by knowing that the hygiene, which is missing to them only by unfortunately religious circumstances, where God did not tell them to clean so many times, because possibly they've been busy in their lifetime. So it's very important. Uroflowmetry is all about looking at the graph. So when somebody closes his eyes in the audience and look at it, you can make out that when men and women pass urine, it comes with a great flow, and then there's a crescendo and a decrescendo rise, and finally nothing should be left over. So in young parallels who are seated across, it is important for us to know that the residual volume should be as minimal as possible. So somebody asked me, what is the normal residual volume? Normal residual volume could be 30, 50, and 75 ml, acceptable. But when do you check a residual volume? Only when the bladder was full and somebody emptied the bladder. In a partially full bladder, even you and I will today not get up to pass you. So if the bladder is full, you perform your best and you pick up everything. That is what is important. And therefore, uroflowmetry is important. The behavioral modifications in a quality of life disease like incontinence is what you put upon the patient. And what you tell, you educate them, you tell them to do a timed warding, disregard the bladder sensations by projecting and probably concentrating on something, delay the warding, therefore reinforce the bladder and look at pelvic floor exercises, which are very helpful. That's the way we look at toning the entire bladder around. It is important for us to understand that fluid restriction has been practiced and need to be practiced if you are drinking tea, coffee, alcohol at night and then getting up multiple times. If you're drinking too much and getting into a train where the train will not stop, you will have to empty your bladder before you leave a building. Therefore, drinking small amounts and less or so at night so you can get a good night's sleep and regenerate yourself is important. Also need to be aware that avoiding bladder irritants is important. That means all carbonated drinks and all kinds of chocolates and spicy food can actually cause bladder irritation, apart from the UTI, which is causing bladder irritation. All urologists and gynecologists are guilty about missing out constipation. All of us miss out. Unless we talk about the constipation part, which contributes to urgency, because the bowel being filled up out there, the bladder being pushed, and therefore emergent. It is important that the bladder needs to be emptying well with a normal thorough cycle. Therefore, Must ask patients not only give them Clemafin Plus and Dufalax and Dalcolax, but put them on issues, which is about avoiding constipation. Get them more saag, salad, and sabji, or give them more fibers and fluid intake, and they would get well. If you increase the fluid, overactive bladder will challenge them. Overactive bladder is a lifestyle phenomena. We need to look at how to prevent. And therefore, the available treatments that you and I do are behavioral therapies, pelvic floor therapies. But remember, they all, according to the reviews and Cochrane reviews, alone don't stand effective. They alone don't stand effective. We got to look into helping them out with the drugs that we have known over decades. Now, in the past, the mainstay of therapy in current overactive bladder therapy was always antimuscarinic. You remember the drugs? Tolterodine, fesoterodine, propiverine. You remember darifenacin, you remember solifenacin. All these are those drugs which are such an important aspect. While we are inching gradually in the week, which is women's health, it is important for us to treat our women and not let them wear diapers at home. Therefore, overactive bladder mainstay of therapy in the past was a completely different story, friends. You all have treated them with a milder and a best drug called solifenacin of all the groups. It is important for us to wake up to that. Now, remember, in the era where I trained and you trained and our urology teachers trained, it was always an overactive bladder treatment with muscarinics. It is so important for us to wake up that they had side effects. They had side effects which were limiting dosages. In other words, you cannot give them full dosages because they had adverse effects of dry mouth and constipation and blurring of eyes and contraindicated in glaucoma. And many of these patients, therefore, would not be able to continue the drug. So the adverse events were so limiting in such patients that we had to stop these medicines. Not that we stopped, the patients gave away. They had dry mouth as high as 20 to 35%. They had constipation up to 1/5 of the patients. They had upper abdominal pain, griping, dyspepsia, nausea. Don't forget, the pharma companies across the world did not talk about something called cognitive dysfunction. There were elderly women who were treated with tolterodine and with fesoterodine and with darifenacin and other drugs, and they would actually come back and say, doctor, my overactive bladder is very good. I don't wear diapers. I can reach the washroom. But what has happened? I'm feeling a little dizzy. I'm feeling a little weak. I'm feeling a little lost. And we would never believe them because we were never taught more than this. Remember, all these drugs also in long term have cumulative cognitive dysfunction. Therefore, it is important for us to understand that our era of past was possibly subminimal therapy. We could not give them full dosages. We could not treat them completely, but we were still urologists, gynecologists, and urogynecologists. All these patients would stop therapy except for solifenacin, which had the least amount of stoppage. We had to wake up to the phenomena of how to continue the drug. For example, remember tuberculosis, many of the patients would stop the TB therapy. Their fever is gone, their weight has picked up, they are very happy with their diet. They would stop tuberculosis therapy till you force them, and therefore you would see them monthly in various departments. Similarly, once the overactive bladder is gone, you put them to right therapy, they would stop and then they would come back again. And that's where we were always searching at ideal muscarinic, which would not cause those side effects, and also which was not known to us until a decade ago, the cognitive dysfunction. We searched and searched, and the world did research on that. And finally, we finally understood that the goalpost had to change in 2011. In Japan and in United States, the algorithm was getting longer, and we were waking up to phenomena till we got this drug called mirabegron. All those friends, gynecologists today in India who are actually watching this, proud of you that you're watching this important aspect, that you know the drug. And if you don't know, you would look at this drug as a possible therapy for most of your patients of overactive bladder. It's a novel first-in-class, approximately 10 years old drug. 10 years old drug. But to it, looks like only yesterday that it came 4 years ago to Mumbai, to India. That's when we as urologists in India started only 4 years ago. So in 2011, it actually was approved in Japan. In 2012, it was approved in the United States by the US FDA. This drug was never born for overactive bladder. It was a drug which was being tried for NIDDM, for diabetes mellitus. But patients with diabetes mellitus felt very good on overactive bladder. And it was extremely important for the company, which was at that time called Yamanouchi, later on became Astellas, a Japanese company of that standing, which did the drug trial in the world. They actually said, no more NIDDM. Let us look into the overactive bladder. And that's how the first in the class of beta-3 agonist drug had arrived. This is something like Viagra, where the Viagra was being tried for heart, and all these patients had great erections. And the whole thing from heart was forgotten, became erectile dysfunction drug, and the highest sold drug in the history of mankind. Similarly, mirabegron, which came 10 years ago to the world, came to India approximately 4 years ago to urologists. And I'm speaking to you today in the Women's Week or Women's Day week to get more patients treated on the overactive bladder. So friends, need for the newer agent was always there. 10 years after the drug came, an Indian gynecologist today is going to pick up this drug because many patients stop anticholinergic medication with side effects and discontinue the drugs. And therefore, we need to wake up with mirabegron. What does it mean? Mirabegron is the first drug in the class approved for overactive bladder. It is established as an alternative monotherapy to antimuscarinics, or it could be combined with antimuscarinics like solifenacin, which is a milder kind of drug, and therefore they may not have side effects. So what a great stuff to happen. Beta 3 agonist can be treated, used alone or used with solifenacin. Let's go to some scenarios and look at that. What does it do, which other drugs did not do in the past? It suppresses the involuntary detrusor contraction in the storage phase. It does not interfere with the voiding phase. This is a great plus point because many patients in the past actually would land up with retention of urine as men and women who were given solifenacins and tolterodines and full dosages while giving them side effects because it would interfere with the contraction power. This would not affect with the emptying mechanism. It will only suppress the involuntary detrusor contractions. Now available in the country with two dosages, 25 and 50. Let's look at it. The 25 and 50 are recommended, and it's looking like that we would start with 15 more younger patients and 25 in more older patients. This drug can be taken as early in the morning as you get up. That's what your patients can do. They don't have to have a breakfast and wait for the breakfast. They can take it empty stomach. 25 milligram is what we started as urologists. Let me confess some of these important points as key points and tips and tricks, which I did talk about as important landmark stuff, which means that patients who had very serious symptoms seen by me and go to you should be started with a 50 milligram drug. Don't start with anything mild. 1 spoon of rice will not work. 1 spoon of sugar will work. They need a bowl of rice. Therefore, they possibly would require the full dose, improve, and then if required, de-escalate. So let's give you two scenarios as gynecologists and urogynecologists. Number one scenario, start with 25 milligram mirabegron if you're worried about. Assess them in 2 weeks. They may say, we got this much results, doctor, but not that much that you had promised or the drug promises. Then you can, in a needy patient, escalate them to a full dose and see them again after 2 weeks. And you will find the results are coming and you're happy about it. Compared to some in whom you would say, I will now start the solifenacin, the old drug, which was an effective drug in the past. So you could do two things. Somebody who started with 25 milligram, who's an elderly patient, who's also possibly hypertensive, 25 milligram. So he said that, Dr. Pandey, 2 weeks later, I've got this effect, but can I get better? You said, yes, I've got in store the next spoon of rice for you. And you gave her 25 milligram more. So you give 50 milligram at breakfast, and she does great for the first 18 to 20 hours. She will sleep well at night. While that is happening, it's good. You are looking at that the blood pressure does not get escalated because of this. The only contraindication to this is this drug is uncontrolled blood pressure. If there's uncontrolled blood pressure, we'll be in trouble. Friends, we are nearing our closure time and I'm moving on a little rapid pace. I'm sure Zydus colleagues are actually recording it. Let's go to the second aspect. You could add solifenacin to the existing 25 milligrams, will be good enough. So you could start an elderly woman with 25 milligrams of mirabegron, give them 2 weeks, and then when they come back and say, can we get better? Add a 5 milligram of solifenacin and check that they're not constipated, they're not having cognitive dysfunction. Are they good enough after 2 weeks, after 6 weeks and 12 weeks? Good enough, continue that. But I would recommend that we should go for a 50 milligram in all patients who are not hypertensive, all patients who don't have labile hypertension. Labile hypertension. That means the blood pressures are there, but they are well maintained. Go for that. That's where here, all young women in their 20s to 50s who are non-hypertensive and who have attempted or failed therapy by me as a urologist and goes to you as a gynecologist, please start them with 50 milligram once a day, even before breakfast. They're great. They're actually marketed by many companies around, including our gynecological companies, as mirabegron, which comes in many trade names. Assess them in 2 to 4 weeks, not only by looking at a frequency volume chart, and that's always required. Ask the patient to bring about a voiding diary, and you can show them a voiding diary before start and after start. And the patient will say, my report card is in front of you, and I'm happy about it. And that will change the whole life. So you will look at a post-word residue because the residue should not rise, which could rise in a partially obstructed patient where there's already an overactivity, but the obstruction has not got treated. So look at a post-word residue, look at a frequency volume chart, get these patients to do well. If they're hypertensive and they have got changes in the blood pressure, medications required, you will have to go down on the solifenacin. And that's where there is a black box warning in them that if there's increase in blood pressure in these patients around, which is only cases of labile hypertension, then you will have to wake up to the phenomenon. They normally don't cause urinary retention like the past medications and antimuscarinics. So next time you think about urgency, next time you think about urge incontinence, next time you think about increased frequency of urination, or you think about nocturia and post-voidable, you are thinking actually about the women with overactive bladder as females and looking at Mira background, because these women deserve your care. They need to be empowered, and what a way to empower them on the Women's Day. It's important for us to be. There's a small subset of patients who may not respond to any drug, and these are called refractory overactive bladders. Like I have my patients whom you refer as refractory erectile dysfunction. When nothing works, they are diabetics, and I put them on penile prosthesis to get an erection and capable on the bed. Similarly, there are refractory overactive bladders when no drugs work. And when you refer them out, we do urodynamics. Urodynamics here on both the curves shows the third line, the pink line, which actually is a bladder line. The pink line or bladder line during filling phase should be completely silent. While your bladder is filling right now, the bladder should be silent and continue to fill, fill, fill. It should not contract there. But you can see that the pink lines or third lines are contracting up and down, up and down. And when they're contracting, the blue lines are active, which means urine is leaking. So in a filling phase of bladder, if the bladder contracts erratically and has not responded to any medications, it possibly is a refractory overactive bladder. One needs to prove. And these kind of patients are treated with botulinum toxin. Where I inject botulinum toxin, and few of your gynecology colleagues have taken it up. We inject 200 units of botulinum toxin in urogenic bladder and 100 units in the bladder, and silence the bladder to lesser levels. And in one way, bring about a chemodenervation of the bladder temporarily for anything between 6 to 9 months. It is very effective for that point in time. In my hands and some of my colleagues' hands, including the world trials now in the last few years, patients are even effective up to 12 months. That means at the end of 1 year, they would say, it's time for me to get the Botox injection in the bladder again, because it's approved already by the US FDA. Unfortunately, by that time, there are sproutings of nociceptive efferents, and the bladder again becomes contracted. It is important for us to wake up to that phenomenon. I also inject botulinum toxin in the vaginal wall, on the vaginal muscles, which are basically refractory to the vaginismus, where a therapy of all kinds of psychosomatic activity, possibly dilatation by few, and a psychiatrist's opinion has not worked. These are all young women who get a botulinum toxin in the vagina because they are now into refractory vaginismus, something which I've done for the last 14 years. So something which I put in my writings in the botulinum toxin in urology, the book that we worked on across the world, and therefore the campaign of incontinence arrives to you today. As I got older, my incontinence became worse. I'm so glad I did something about it and saw a urologist. Now I can enjoy life again. Time for a gynecologist to take charge. Friends, incontinence needs your efforts, needs your attention. Don't leave it alone. Good things do take time. I'm coming very close to the end of my talk with the last few slides, because a journey of 1,000 miles begins with a single step of partnership with a gynecologist and a urologist. While we're looking at all these awareness, and your clinic has a positive vibes and team member works on incontinence, armed to the core from anything between a Mira background 25 or 50 milligram or solifenacin to combine, going all the way down to refractory overactive bladder, where you would look at botulinum toxin, and few of us do it in the country, and look at 6 to 9 months of dryness. You also need to wake up to a phenomena which I would like to talk about is interstitial cystitis bladder pain syndrome. It is something where a pain on bladder filling happens around. If the bladder filling up gives a sensation to you and me, then it's fine. But if bladder filling up gives a pain, then it's a disaster. And we don't want that to happen. This is something which I need to wake up everybody. A woman who has got a bladder filling causing pain and it's a flaring up is possibly having a pancystitis, and that could be something which is called as interstitial cystitis bladder pain syndrome. Women suffer 9 to 10 times more than men, and they continue to live this battle every day, where when the bladder fills up, they've got discomfort. The pain could be in the region of the vagina, the urethra, the rectum, the entire introitus or suprapubic region, something which we need to wake up. Therefore, they get the urgency frequency, but that urgency frequency is not an overactive bladder. That's not an overactive bladder. Overactive bladder is never accompanied by pain in the bladder. It's accompanied by urgency frequency and urge incontinence. But here, a flare up happening with a UTI, the bladder going through this agony, you will have to wake up to the phenomena, because this is something which is very important. And let me tell you that RCOG came up with the latest guidelines in the outer world from the gynecologist on management of bladder pain syndrome. That I happen to be the academic head or secretary of this important group called the Global Interstitial Cystitis Bladder Pain Syndrome, of which you have all have been part of, and we do conduct meetings city by city around. There are safe clinical practices which I have. I could actually pass it to you on the WhatsApp if you probably pick up my number and send it to me. These are safe clinical practices which we have looked at, clinical practices, not about just theoretical guidelines, which we have amalgamated for patients in India. And this is something where patients with bladder pain syndrome get a relief. Women continue to have bladder pain syndrome may sometimes in a domain called interstitial cystitis have a shrinkage of the bladder. And these bladder could possibly become a very small capacity bladder where we may have to do an augmentation cystoplasty. So I will not go into depth of it today, but I will come to the end of my discussion by looking at these patients could be coming to your clinic. So how do we classify a patient who comes to your clinic? All women who visit to visit your clinic, look at this. They could have pelvic pain, pressure, or discomfort. So all women who have got discomfort at one point, at the same time have got urinary frequency, urgency, forced frequency dysuria, could be cases of target disease, could be cases of interstitial cystitis, bladder pain syndrome, where they could be having pelvic pain, discomfort, and everything going down all the way to the vagina, rectum, all those areas, and they are also having urgency, frequency, and urgent incontinence. It may confuse you with overactive bladder. That's something important. And therefore, this important slide of diagnosis of bladder pain syndrome or interstitial cystitis by gynecology colleagues today in the audience. Patients who are refractory to your treatment, look at them. Patients who have been recurrent UTI and they have been treated. Chronic pelvic pain, exacerbated introital pain, and patients who have been treated with overactive bladder situation, but they have all failed. These are the patients who we need to look at. So it is such an important issue that we need to look at such patients and give them a life of their own. Patients who have been treated as concurrent endometriosis, a very common diagnosis which gynecologists go through and probably treat and take them in a journey with hormonal therapies, with surgeries. It is important that if these patients have failed treatment, or it could be concurrent with that the patients could have bladder pain syndrome. So if you have patients who are refractory to urgency, frequency, pain, discomfort, pressure in the pelvis, in the region of the bladder, introitus, please wake up to a phenomena that it's not a recurrent UTI, it's not an overactive bladder. The two important topics we discussed. These patients could be a case of refractory situation, which is a bladder pain syndrome, something which I get to see 7 days a week referred from all over the country and the world, because we look at the Gibbs, and I want to pass you the Gibbs guidelines. If you get a new patient from tomorrow who has got urgency, frequency, but has got a pain and discomfort when the bladder fills up or when she passes urine. It's not acute for 2 to 4 weeks. It has been 3 months to 3 years or 3 decades. She has got dyspareunia. She has given up sex because clinical examination, a vaginal examination, anterior bladder wall, anterior fornices are all painful. The bladder is inflamed out there. It's a pancystitis. And she gets a relief by voiding. I empty my bladder, I'm comfortable. Otherwise, I've got a burning sensation in the introitus, Dr. Pandey, and I have not got treated. I've got cultures after cultures. The burning sensation was never a UTI. So let's wake up that all burning sensation in women during, before, or after passing urine is not a UTI, please. All burning sensation not during passing urine. When the woman is not passing urine and she has got burning in the introitus, burning pain in the region of the introitus, vagina, rectum, suprapubic region, is possibly a bladder pain syndrome. Dysuria is something which is acute, which women get because the urothelium is inflamed, which you treat with antibiotics and probably suppress and cure. But those women who have got burning sensation in the introitus continue to have discomfort, have overactive bladder resulting from the forced frequency as a result of the urgency frequency. These women go to the trauma. And therefore, you look at all the investigations and finally prove that there is nothing wrong. I will leave this and look at the last slide of the bladder pain syndrome. That means pain, discomfort, and pressure on bladder filling relieved by voiding in the early stages and may not get relieved in the later stages. Increased frequency of urination and urgency, or forced frequency. They're forced to go because they know the pain will come. Pelvic discomfort and multi-organ crosstalk with progression. Adjusting the life in diapers, sometimes bedwetting, no treatment available and labeled as mind games, ineffective treatment while disease progresses. All the reports are normal. Therefore, you're tired and therefore you're busy giving antibiotics. These 4 patients could be difficult. Many of these patients could progress to an end-stage bladder. And it's important for us to identify them, look at it as a urogynecological segment, probably team up with a urologist who are looking at bladder pain syndrome, because some of these patients could have a small fibrotic bladder capacity. We have got 2 patients upstairs right now in the hospital who have undergone augmentation cystoplasty, where the bladder has actually been remade with intestines, which we continue doing it. So this is a clinical diagnosis. You could fit in, you could pick up this, and biopsy is only required when it is required. I will leave this, go to the guidelines. Yes, out here, endometriosis is also an important aspect of differential diagnosis which you need to look into. So for the sake of it, it requires a multimodal therapy. A therapy where there is injury, insult, potassium leaking into the urothelium, interstitium, and histamine mast cells going on is about to be treated by treating various aspects of bladder pain syndrome, something which we cannot discuss in details today. But to give you an idea that so much involves in bladder pain, the bladder pain requires a treatment with umpteen aspects. Therefore, you can understand that in the American Association of Urology, there are various tiers and sets of management from first line to sixth line. Sadly, I'm involved in the sixth line more frequently and less on the first line, which means I treat patients on pain, but also do substitution cystoplasty. Friends, this was important for you to wake up to it and understand that. I was talking about refractory vaginismus and female sexual dysfunction, where they need botulinum toxin in the vagina to help it out. And finally, before I come to a close, I must say that women are also born without a vagina in vaginal atresia, and women are also born without a uterus and vagina in MRKH syndrome, something which we do because I'm involved in gender reassignment surgery in both male to female and female to male. If a woman is born as a congenital atresia, when she develops a menarche, she develops this hematometra, but there's no hematocolpus because she doesn't have the vagina. The vagina is atretic. Compared to an imperforate hymen, where you will have a hematometra and a hematocolpus, where a cruciate incision will open up everything. But in hematometra, you have the congenital vaginal atresia. And we continue doing few patients every year where we either put a sigmoid segment or an ileal segment, interpose it to create a vagina from the level of the cervix, which is effaced with the hematometra, all the way to a new introitus, which is the vagina. For women with MRKH syndrome, where they have got ovaries which make them young and beautiful, but they've not been menstruating since the last 2, 5, 10 years, and they are picked up at the age of 17 and 20, or even at the marriageable age, we know that the uterus is missing and the vagina is missing. For them to become a woman and being acceptable at that age, where they find that they are deficient because God forget to give them uterus and vagina, it is important to identify MRKH in time. I've been doing 4 to 7 MRKH every year, initially by open surgeries. Now people who can afford by robotic surgery, where they do a sigmoid vaginoplasty. A sigmoid vaginoplasty is different from HRT and other stuff around, where you get a non-peritoneal kind of line. You get a tube, which is completely effective, 15 centimeters of vagina, which in early days may have some secretions, which normally undergoes a metaplasia. So friends, I would come to a close. We are running out of time at this point in time, and would make you understand that urogynecology is a big segment. To my initial slide where I talked about women develop recurrent UTI and they live with overactive bladder. Two important phenomena which you would take up clinically, and you do it regularly in your clinics. The positive vibes in your clinic would make patient understand and stick with you. You would look at those aspects and get treated. When we move from that aspect, remember, a painful bladder syndrome is not recurrent UTI and not an overactive bladder. The bladder fills up, she gets pain. She has burning sensation not while passing urine. She has burning sensation all the time. These are the patients where we need to look into. I do a multimodal therapy in such patients, which you also could pick up when you're part of GIPS. We need to look at these patients to treat it to the next level altogether. And finally, when you look at women as such who develop incontinence with stress incontinence, I still continue doing the old pubovaginal sling at the mid-urethral sling. And women do come and undergo a cystocele repair along with the mid-urethral sling or a pelvic floor repair. Rectovaginal fistula happening either by trauma or by injuries or by malignancy or by other aspects of injuries which could happen urogynecologically are important as much as the vesicovaginal fistula and the ureterovaginal fistula. Friends, pelvic ultrasound is not the final thing. An ultrasound abdomen and pelvis picks up possibly a hydroureter nephrosis existing in a female patient whom we are about to operate. And such patients would deserve that they possibly get the right approach, and possibly they would be seen by a urologist before you take them to a surgery. So when we look at the larger domain of urogynecology, there's so much to discuss. I could not have taken that forward immediately. But if there are any questions in the next few minutes, I could have answered. Dr. Isha, if there's any question that you want to pick up beyond the large monologue I gave, because I did not have a chance to actually see my colleagues in gynecology, and on a wonderful Women's Day celebration that comes up around where we empower women on all aspects. I think you and I stand tall in terms of being able to empower our gynecology colleagues to do more urogynecology, pick up all those aspects, treat the recurrent UTI, prevent a recurrent UTI, possibly use track free on one side, femba on the other side, possibly be friends with your urologist, pick up things early and complicating factors, and don't let bacteria only be treated. Look at them being counseled about sexual hygiene, about midstream urine specimens and cultures. Look at them taking a journey where they don't require you and me all the time. Friends, I call it a day. You can ask me questions if there are any. Dr. Isha, any question which I may not have answered in?
Yes, sir. Yes, sir. We have a few questions here. So the first question is, which is the best way to collect culture samples from a catheterized patient? Is it by pricking the port channel or by discontinuing the catheter from the urobag?
So remember, unfortunately, you and I would not be collecting. Our sisters need to be trained. So there are new kind of Eurobag tubes available where there is a area where you can prick and suck it when you clamp the catheter. But the traditional techniques are both. You have still clamped the catheter for 10 to 20 minutes and taken a very thin bore needle and probably sucked out. You have put a needle and sucked out from the tip of the catheter outside. Or you could clamp the catheter, clean up everything and collect it. So the collection has to be very clean. That means you have had everything clamped and then you pick it up, and that should be good enough because you let something drain down and then you pick up something. That's good enough. I would respect that. Remember, you're collecting it from a catheterized specimen. Remember that, very important. You would always have some pus cells and some RBCs. Catheter causes a little bit of whatever element of cystitis. You will have some pus cells. Pus cells are not pus cells, they are WBCs. Wrongly labeled in the world as pus cells, they are WBCs, number one. Number two, there'll be some RBCs around. So don't look at urine routines when you have a bladder stone or a kidney stone, when you have got an indwelling catheter or SPC or a stent. Please don't treat the pus cells in urine routine in such patients. But yes, rightly ask a question, urine culture. Ask them to give a good clean catch midstream urine specimen, not necessarily early morning. But if you have a catheterized specimen, you only do a culture if the patient is going through possibly a fever or possibly something. You don't want to treat some bacteria which are colonized. All patients whom you catheterize in 3, 5, 7 days are completely colonized. They're completely colonized. They've got 100% bacteria inside. They are friendly bacteria. Like when we brush our teeth, the bacteria is still in our mouth. We think that our mouth is fresh. Bacteria still stays there. You clean the introitus, bacteria still is there. So therefore, bacteria will be colonizing a catheter in 3 to 7 days time in all patients. You need not treat the bacteria, please. These bacteria are friendly neighbors. They will stay there. Unfortunately, if you're worried about colonization, use this expensive Bactiguard catheters, but that's not required. So these patients who are catheterized long-term, very important for us to speak this forward. Long-term catheterized women who need catheter for months, years, it's ideal to put them on suprapubic cystostomy. If you put them on suprapubic cystostomy, you diverted the urine from the abdominal wall, from the bladder. The whole introitus is not being soiled. The catheter does not work for contamination, and the catheter does not work as a ladder on which bacteria keep walking up and down and give a susceptible patient a UTI of the ascending kind where she develops a pyelonephritis. Or the catheter being there for a long time would not cut through and cause a vesicovaginal or a sphincteric fistula altogether. So for long-term catheterization for months together in patients who are paralyzed, in patients who are developing stroke, these patients would deserve a suprapubic cystostomy. Otherwise, you keep treating the recurrent UTI and they don't get well. You kill their bacteria, the new bacteria comes in. Therefore, identify the cause of bacteria. But these patients with catheter and stents could develop a complicated UTI. That's what the answer was.
Thank you. Thank you so much, sir. The next question here is, what are the mesh-related complications in urogynecology who have underwent pelvic floor surgeries?
Wonderful. So remember, for all practical purposes, most of the mesh have actually been abolished. Sadly, we're going back to the era where we'll do anatomical repairs, or we will look at our own pubovaginal slings. I do a shorter pubovaginal sling with the sutures which hold it in distance. In other words, the mesh now only stays as a mid-urethral sling because the manufacturing of most of the slings which came from Johnson & Johnson and other companies have been stopped. So the mesh-related complications are the one which brought the genesis of the US FDA to look into, and what was a wonderful 20 years journey on many patients who did well was also a sad journey in many patients who had got complications. So to answer your questions, the complications where the mesh got extruded, the mesh was actually too tight. It was never made to be too tight. Mesh was only a support to be put. For example, let's look at a very simple surgery called a mid-urethral sling. You are doing a tension-free repair. You're doing a tension-free vaginal tape or a tension-free obturator tape. If you put it too tight, if you go into the wrong place and pull it too tight, you would have a cut through. And patients have come cut through after a few days, few weeks, few months, even few years. So that was one. When the complex meshes were used in the pelvic floor repair, sadly, most of these meshes actually fell into disarray. Many of these meshes actually got extruded. Many of these measures were actually got crumpled. They went into extrusion, they went into foreign body reaction, and these all actually brought about a situation that pelvic floor repair would never happen with mesh anymore, which means anatomical repairs took the roost, which we are the compartmental treatments that as my gynecology colleagues do. But mid-urethral sling still says I still use few of them. So I've converted myself completely to a pubovaginal sling only for the reason that the patient who comes to you is a very learned patient today. They go through Google, they know everything. You will have to take a consent from them that are you agreeing to a mid-urethral sling of a kind which is synthetic. Many patients say yes. But the patient who don't know, you will have to give them an option and say that I could do a pubovaginal sling. I do a very small incision at suprapubic level, get the pubic sheath around, go down and utilize it as a tension-free tape. So I use it as tension-free tape, giving them attention. But once you use a pubovaginal sling, like the way you do a TOT, there's no risk. There's no risk of erosion. You are actually putting it to a level where you make them cough under spinal anesthesia, and most of the patients do well. So we have now converted a pubovaginal sling to a TOT or a TVT kind of technique without having a trouble.
Thank you, sir. Thank you, sir. Next question here is, a newly married couple, female complains burning urination every time after intercourse. Culture is negative, no comorbidities, and no use of lubrications. What is the way forward?
Perfect question, please. And this is so common. All my gynecologists, patients, doctors, colleagues across the country face this. That means there are patients who actually go through this trauma. The trauma when they are actually going through the happening where women develop honeymoon cystitis. They may not be doing the sexual hygiene of the location. Imagine this. Let me just show you this. For the sake of understanding, look at it. Then you have a urethra there. You have a urethra there. And the urethra is not colonized by bacteria. But just behind the urethra is the vagina, which is colonized by bacteria. And then there's the rectum, colonized by bacteria. All the three open into a common introitus. And this common introitus that you have there, that area, the bacteria could easily walk up all the way from the urethra up the bladder. So she needs to maintain a sexual hygiene, number one. These are the patients who, as I said, are premenopausal or young women, and they have no major risk factors. There are no obstruction like the post-hormonal changes. Such women would do very well with the use of probiotics. You could put them on FemBio, you could put them on tract-free XT, you could put them on a low dose of prophylactic for a while, or put them on a post-coital prophylaxis. These patients could invest on a post-coital prophylaxis where they could have, unfortunately, not a planned sexual activity, but they could look at having their antibiotic post-coital, and they could be on FemBio for a longer period of time while they learn and practice the sexual hygiene, washing up, cleaning up the whole introitus very well, and passing urine after the sexual activity before they go to. So maintain and practice a good sexual activity, which is sexual hygiene, sorry. At the same time, while you continue doing that, be on FemBio or Track5 XT. While you're doing that, give them all that antibiotic prophylaxis just before their coitus or just after their coitus. Maybe one dose could work. I don't want to promote fosfomycin here, but one dose antibiotic could even be nitrofurantoin or a third generation cephalosporin, or could even be a fosfomycin. On the very select case who's getting a UTI, which is causing her life to be in disarray and sometimes goes into pyelonephritis.
So a question similar to this is that in such scenarios, if the woman is now trying to conceive, will the advice will be similar?
All the more similar. In such patients, it has been seen that the probiotic does not have got a very big side effect. In women who wants to conceive and is getting recurrent UTIs, is in deep trouble. Trying to conceive by natural techniques on the bed or trying to conceive by artificial reproductive techniques. In both the ways, if you have got cultures positive or you have a UTI, your gynecologist will not be able to take you forward. In such situations, a probiotic is a great boon today. Before we landed up giving nitrofurantoin 3 times a day, then once at night, or using trimethoprim, sulfamethoxazole was always a scare in Indian patients regarding the sulfa drugs activity. And therefore, a probiotic has been a great activity. So I would look at interacting between FemBio and Track-free XT and looking at these patients, learning sexual hygiene to very high levels and using probiotics to very high levels. It actually helps them. There are no side effects. These are ideal drugs.
Thank you, sir. So the next question is the combination of cranberry and D-mannose, as you mentioned, is it safe to be used in pregnancy?
So I would look at this safety aspect not in the first trimester at all. A first trimester is a very difficult trimester. At that trimester, not many drugs of any class have been actually attempted very well. If you have that kind of stuff where you have got a worry about somebody who would undergo a spontaneous abortion, which is happening more in the second trimester kind of thing around, that's a time when we have used a prophylactic dose once a day, and that has been effective. We have not used in nursing women, let me be very, very clear. In nursing women who are getting recurrent UTI in the first few months after their pregnancy, around after the delivery, do not use track-free XT very frequently. And if it has been used by us, it has been only once, compared to twice a day, which is the normal usage phenomena. You only once. So we use with a word of caution, please, because they're not being found to be secreted in breast milk. But at the same time, you use a lesser dose. At the same time, you get into a more overt kind of a sexual or a hygienic practice which you would do. So a lesser dose is good in the second trimester. Lesser dose is very good in the nursing women. These are the patients who are a little in catch because they're getting UTIs. They become sexually active post-vaginal delivery and they're getting UTIs. They need to look at washing, cleaning up more frequently, looking at that balance which you need to strike.
Right. So another question here. Why does complicated UTI occur only in post-menopausal women? Is it because of the strictures or the anatomical defect?
Absolutely. So you answered the question, Dr. Isha, very clearly. Complicating UTIs happen because of complicating factors. And the complicating factors are huge. One way are the functional factors, diabetic cystopathy. Diabetic woman having a diabetes for 10, 20, 30 years, the bladder has lost its power of contraction. The residual volumes are high. She doesn't push it out. Patient with spinal diseases, they cannot push the urine out because the bladder has become hypocontratile. Now we're coming to your cases where postmenopausal women, the hormones have gone away. Many of these introitus are actually tightened up. You may not know till you do a uroflowmetry, the flow could be flat. These are the patients postmenopausal have got the lactobacilli which has disappeared and the uropathogens have walked in there. So postmenopausal changes bring about. Estrogens have disappeared. You using estrogens can reverse them in a perimenopausal age compared to very elderly women. So obviously postmenopausal stage is actually a stage of complicated UTI being emanated. It's one of the factors where complicated UTI develops. It's a long list of complicated UTIs I talked to you.
Sure, sir. Thank you, sir. And the last question here is, some women show growth of staph aureus during pregnancies, significant growth. What do we infer? Because there are no symptoms here.
Yes. So remember, pregnancy is a little catch situation. In pregnancy, the only time where you will even treat an asymptomatic bacteriuria. Remember that. Because asymptomatic bacteria of pregnancy can lead to, one is fetal loss and one is a severe acute pyelonephritis and a mother developing emphysematous pyelonephritis. So these bacteria, if they grow to such levels that they are colonizing in the urinary passage of a woman who was given a proper sample. Remember, always repeat a sample. Very important. If you do a staph and streptococcus, please look at a proper midstream clean cat specimen. If that cannot happen, take a catheterized specimen or a suprapubic aspiration. You got to get the right specimen first. It should not be an introital coiling, introitus which is soiling it. If that is what is happening, you're still getting staph. A staph will need to be treated. Very, very important. Staph aureus can also cause UTI. It's not that it doesn't cause. It is a commensal most of the time. But if it's one happening around, I think you and I will be emphatic to take charge during pregnancy. Asymptomatic bacteria of pregnancy is to be treated, whichever the bacteria. You could identify that this is the right specimen, the right patient, don't delay it. You will have to look at the right antibiotic, antimyobacteriogram. Look at your microbiologist colleague too. They are very important when it comes to these kind of patients. You got to balance it looking at the first and second trimester. Many of the times they have been sadly treated only with nitrofurantoin. But that's an era where fosfomycin has walked in. It has a broad spectrum of activity. You'll have to still look at antimicrogram to prevent one developing in the later UTI, later part of the pregnancy.
Thank you so much, sir. Thank you so much, sir. So we would like to call it a day. Thank you, Dr. Pandey, and thank you all to all the doctors who joined us for this session. I would take this opportunity to wish everyone a happy Women's Day in advance and have a good day, a good time. Thank you, sir.
Thank you, everybody. Have a great Women's Day, and congratulations for all of you joining today. I'm sorry I exceeded my time. I just came back from a long operating day, but wanted to push in as much of information that could be probably done. You already practice it. Continue doing well. My WhatsApp number for you is 932-471-8283. 932-471-8283. Only for the reason that if you have cases of bladder pain syndrome, if you have complicated cases of UTI and complicated cases in urogynecology, you could always send me in a WhatsApp. I miss it out during daytime, but nighttime I would like to answer you. I'd like to answer you. Possibly in the city of Mumbai, I could see some patients, but my colleague urologists across the country who partner with all you gynecologists and urogynecologists, it's a nice treat to be partners in the pelvis where we can combine together and do well for women's health, which arrives today in few days' time on the Women's Day, where we empower ourselves on one side as clinicians and other side empower women who should be aware of diseases and reach the doctors in time. Congratulations to all of you. Congratulations, Zyrus, for having taken up this opportunity to create this actually in time. I call it a day two. Thank you.
Thank you, sir. Thank you.